Coming up today, a closer look at advanced medicine that's changing outcomes for patients with lung cancer. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. When a small spot was found on Lori Blevin's lung, her doctor referred her to the University of Kansas Health System. Doctors here are using the latest technology with the most precise tools available. This is video of another patient undergoing robotic technology, which helps doctors find, diagnose, and remove cancer with remarkable accuracy. From diagnosis to surgery, two specialized teams work together to guide Lori through her third battle with cancer. This time, she's not just surviving, she is in full remission.
But if I could have Christmas every day, I would do it. I love this tree.
With her year-round Christmas tree, yes, she does adjust the lights based on the season.
So there's Halloween, July 4th, red, white, and blue.
Christmas decorations, board games, and Hallmark holiday movies on repeat.
All year.
Lori Blevins does what she wants, when she wants, which also explains the purple hair.
I don't want to be gray.
It also explains why Lori wasn't about to cancel her family vacation to Hawaii, even when she was recently diagnosed with lung cancer. But Lori's first of 3 bouts with cancer was 32 years ago.
All my organs, the cervical, the fallopian tubes, everything.
She had a full hysterectomy and was cancer-free for a year when doctors found another tumor in her lung. Surgeons removed her right lower lobe, and Lori was again cancer-free, this time for 30 years. But when she went to the doctor for some leg pain 11 months ago,
And when they did the CT, they were like, what is that?
her leg pain was the least of her worries. The CT scan detected a tumor, this time in her other lung, but they needed a special kind of biopsy to confirm it was cancer. Which is how she met University of Kansas Health System interventional pulmonologist, Dr. Michael Postigo, and they hit it off famously.
He came in and said, oh, by the way, it's going to be a robot that does it. And I said, excuse me? He said, now, not a real robot. He goes, that's not going to be, I'm going to be there.
Dr. Postigo performed a robotic bronchoscopy.
We are going to tell the system that the virtual part is matching the real.
Guiding the equipment through a breathing tube into Lori's lung to take the biopsy.
They're like over there, sitting at this machine and doing, yeah.
When the cancer was confirmed, it was time to schedule a lobectomy surgery by cardiothoracic surgeon Dr. Ali Khan Naji. And yes, Dr. Naji gave her his blessing for him to do the surgery after that trip to Hawaii. And 3 months after that surgery,
I'm in full remission. There's no issues of any kind. See, the lights are like in the branches.
Lori's next order of business, getting those ornaments back up on her year-round Christmas tree and touching up her roots.
So this isn't really even as bright as it normally is.
We're so glad to have Lori with us today. We are just loving that story. So great. And we're loving your purple hair. I love your theory. No gray, just purple. We're also glad to have with us interventional pulmonologist Dr. Michael Postigo and cardiothoracic surgeon Ali Khan Naji. Thank you all for being here with us today. Good to have you. Lori, I do want to just start off by saying that you have never smoked a day in your life, right? We'll get to more on that here in just a little bit. But how are you feeling today?
Good. Yeah, I'm got all my energy back and able to breathe.
Able to breathe. The little things that we take for granted, right?
It was tough the first probably week or so.
Tell us a little bit about the follow-up that's been required for you.
Just I'll have to have a CT every whatever amount of years they want to have one. I think I'll have one coming up in the next 6 months or so, just to make sure nothing reoccurs. And that's pretty much it. Just, I kind of know from experience. So this surprised me because I had no idea. I went in, like I said, for leg pain. So I was having all those tests, and when they said they found a nodule, it scared me for a little bit. But I was like, you know what? let's just deal with it and go from there.
And
So.
remission today. Dr. Postigo, how does a robotic bronchoscopy differ from a traditional biopsy?
So, traditional bronchoscopy and robotic bronchoscopy, even though they share kind of the similar principles, right? Like it's a small camera that is able to go through your airways in order to get us to those nodules, are essentially a completely different procedures. Robotic bronchoscopy has a 3D mapping, kind of a GPS system for the lungs that allow us to navigate through these small airways to get to places that before we were not able to. And it's changing the way that we are diagnosing lung cancer. And again, we are able to capture cancers like on her, like very, very early, that allow us to potentially cure the cancer.
GPS for the lungs. I love it when you break it down in ways that we can really understand. Dr. Naji, how is robotic lung surgery different from traditional open procedures? How does it reduce risk for patients?
Essentially what robotic surgery does is using small incisions in order to resect lung tissue. This is different from open thoracotomies, mainly from an aspect of pain control and the ability for a patient to be discharged from the hospital sooner. It allows for quicker recovery, but it also allows the surgeon to have more of a better view of the operative field, a better lymph node dissection that could actually help the patient from a cancer perspective regarding determining cancer spread earlier, being able to perform the appropriate treatment and adjuvant therapy needed.
Any risks?
The risks, of course, are as similar with any procedure, with any surgery. So we do give them the laundry list of the do's and don'ts and what the risks are associated with surgery. But I think those risks are somewhat mitigated in that the visualization for the surgeon is better, so we have a better idea of what we're getting involved in, and then for the patient postoperatively from recovery.
So Lori, from a patient perspective, what questions did you have when they said a robot would be assisting in your surgery?
I didn't really ask a lot of questions because I knew a little bit about those procedures, but I was like, a robot?
That's fair.
So then I was like, okay, and they're like, of course, they're there doing it. It's just, so it was a little funny at times. So when I tell people now that a robot did my surgery, they're like,
Huh?
what? The doctor wasn't there? No, the doctor was there.
Yeah, he's not just in the corner sipping his coffee.
Yeah.
Taking it easy. Thanks for clarifying. Yes, okay. So what was the difference in healing and the recovery process between this surgery and your previous lobectomy?
Well, my other one was just a laser. There was not much to that. I pretty much went home the same day. This one I was here in the hospital for 3 days, but I had a chest tube, so obviously I couldn't go home. But the rest of it wasn't really that bad. I felt actually good. Like I probably could have gone home the same day, but I was a little tired and, like I said, the chest tube. So once that came out, I was like ready to go home.
Ready to get home.
But I got home and realized that I didn't have the strength or the energy to do a lot. So it took a couple weeks.
Got to take it easy.
Yeah,
be a good patient.
Yeah, pretty much. I had a friend that stayed with me to help me and stuff because I couldn't lift anything or do anything pretty much for myself, so it was a little weird because I'm not like that. I want to take care of myself. I can do everything.
It's hard. It's hard to take it easy.
It definitely
sometimes.
is. Definitely is. Yeah.
Dr. Postigo, what kind of accuracy? You kind of touched on it a little bit, but does this technology provide when diagnosing lung cancer?
So again, I think that is changing the way that we are approaching lung cancer. Before this technology, and this technology is quite new, that started in the last 6 years. Reaching to those nodules in the lungs had been quite difficult. Those nodules tend to be in areas that are very difficult to access. With this technology, we're reaching accuracy that before was not ever dreamed. Like just comparing with traditional bronchoscopy, is we go back onto traditional bronchoscopy, the chances of getting you the diagnosis was around 60%. With this technology, we are reaching diagnostic yields that are close to 90%. So we have a really good chance now to diagnose very early and very accurate lung cancer, which is, again, changing the way that we are going to treat those patients. We have more options for them.
Is everyone a good candidate for this?
For lung surgery, it really comes down to the ability for them to tolerate lung resection. So we are actually removing lung tissue. Unlike some other organs in the body, they don't regenerate very well. So you don't get that back. So you have to have the ability to tolerate having lung tissue removed. So we do check breathing function tests, and we look at numbers that say, what are our chances that the patient's going to be fine afterwards? Will they need oxygen? Will they not need oxygen? Also making sure somebody's heart's okay. We have to be able to tolerate having surgery. So not everybody's a good candidate, but we're finding out that if we're getting people earlier, we're having ability to do limited resections. It really does allow for more people to have surgery.
Well, be sure to ask your questions. You can use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. Lori, I have to ask you, how were you able to stay positive after your third cancer diagnosis? It looked like you have a lot of positive family surrounding you, but that's really tough.
The first time I was diagnosed, it was bad. Didn't know if I was going to live or die. So when this came about, I didn't have any issues. Like no pain, no breathing problems, nothing was stopping me from doing anything. So I just thought, okay, he's testing me again. And so but with the family and everything, everybody, I put it out of my head going, I'm going to be fine. I'm going to be fine. I got a good surgeon, good doctors, and I'm
a lot of trust in your team, it sounds like.
Yeah, so. They prevailed.
and it did. So. Dr. Postigo, can you describe what you see and control during a robotic bronchoscopy? We're seeing some video here.
Yeah, so absolutely. So essentially, I truly have a 3D mapping, to make it simple. I kind of have the Google Maps for the lungs that is already imported from the patient CT scan. And then I will control the camera very precisely with the control, and I am able to navigate, make these tight turns using the airways in order to get to that, area of interest, that small nodule in the lung. Actually, this system is extremely precise in getting us there. We have a CT scan in the room that will confirm the location of that nodule and confirm the location of the camera. When I reach to that nodule that I am trying to biopsy, the system is super stable. So I can just park my camera there and then, put different tools in order to get, enough tissue to establish the diagnosis that we're looking for.
Dr. Naji, explain how you control the robot during surgery.
So essentially, we start out at the patient, and we do place our ports. So they're usually about 5 small incisions, less than a centimeter, and the robot has 4 arms. And we have 1 little assist port. So once we place the ports in, we dock the robot and pass instrumentation into the field. I then move over to a console where I'm able to see a 3D image of everything, as if I'm looking with my own eyes into the chest. And then I control the robotic arms within the chest in order to perform the operation.
So you have an operation coming up at 8:30. You said I have to have you out of here, right? Is that what you're doing today?
Yes.
So what's the prep that's happening? What is the prep to get ready for that? Like, is there a team getting this robot all ready for you to come up and just walk in? Does it?
Well, no, it's not quite. I wish that'd be great. Maybe one day AI will come and push a button and pick the right load. No, but I think right now what we have is the patient is up in our preoperative suite. We have a wonderful set of nurses that work in our preoperative area that take care of the patient, do the intake, make sure they're ready for the operation. Our anesthesia teams, our surgical teams meet with the patient rest before they roll back. The anesthesia team brings them back to the operating room where our OR nurses have already prepped the room. The robot's ready to go in terms of sterility, the instrumentation and everything, and then they put the patient to sleep, we come in the room, we position, we do everything, prep, drape, all the good stuff, and then we get moving. It's a great process that involves a great amount of people, and we are very lucky here at the University of Kansas to have a wonderful team that does it.
So what's the biggest misconceptions about robotic surgery, maybe that people kind of have flying out there that you want to put to rest?
I am not drinking coffee. And sitting in the corner of the room. I am sitting in the corner, but with a machine that I'm actually controlling. So the robotic aspect is the visualization, the ability to control the arms. But it's in the non-traditional way is my hands are not directly on the patient while this is happening. The robotic arms are there, which I am controlling from a console.
I know when we hear robot, we think Lost in Space. Remember that
Correct.
show Lost in Space? Yeah, robot. Yeah, it's robot is like you and like very technical, and so
Right.
it's like the word robot kind of I think throws people off a little bit. So
I think
thank
I
you for
think
clearing
that
it up.
yes, Dr. Google is great. Sometimes people want to check out Dr. Google. They have great pictures there. So.
Okay, good to know. Lori, what was recovery like after the bronchoscopy and the lobectomy? You know,
The bronchial was, I had a little bit of a sore throat. I went home the same day.
Okay.
There was nothing.
and you're back to life completely.
Yeah.
Everything's good.
Yeah.
You're back to
And,
decorating and you're ready for the
yeah.
holidays.
Yeah.
You said you were
Yeah.
kind of back to decorating.
About 4 weeks, I was starting to feel more normal.
More normal.
I was still having trouble like walking distances.
Okay.
Like in the store or something.
Okay.
Because and it would be like a half a breath.
Okay.
I'd be like, okay, I got to slow down, So, but now I could take full breaths.
That would be
and
scary though. I mean, breathing's breathing.
Yeah.
That's kind of primal.
Sleeping was a big issue
Yeah.
sometimes because my husband would hear me like take half a breath, so he'd wake me up thinking I wasn't getting enough air, so that was a little bit but now it's nothing. I mean, I'm pretty much full. If people didn't know I had surgery, there'd be no difference of anything, so.
Dr. Postigo, how does robotic bronchoscopy improve your ability to reach a small or deep lung nodule?
Yeah, no, absolutely. So again, it's changing really how we are approaching to those lesions. Before this technology, we were not able to reach to a lot of those small nodules. So we are talking, when we're trying to diagnose early lung cancer, we are talking on sub-centimeter lesions that are very deep into the lungs. So we need the precision, we need the accuracy to be able to reach there, and the stability, right? Like the lungs keep moving, so we need to move with the lungs in order to be able to get those small biopsies. So yeah, the accuracy of the system is just fantastic.
Dr. Naji, how does this change your approach just as being a surgeon?
I think what really the robotic platform for lung surgery has been around a little bit longer than the one for bronchoscopy. But with Dr. Postigo and his team and the skill set that they provide, it allows us honestly to have to provide better care for our patient population. We're getting cancers earlier. We're able to treat people with precision. The recovery's faster. So I think overall we're doing better for our patients. And I think in the end that's what really matters.
Lori, how important was that trip to Hawaii before your treatment?
Very.
Just very, very, very.
He wouldn't have been able to talk me out of it. It would have really had to been like me not being able to like walk or do anything.
You
that
were
would have been the only
determined.
way. But I was like, I told him when he first came in, I was like, I got a Hawaii trip. He's like, okay.
I bet that happens though. You have those conversations
True,
with patients.
we do have those conversations, and in all fairness, Lori's cancer is not the typical type of cancer that we would say, okay, we need to do this right now. She had what we call carcinoid lung cancer, and that's not usually smoking related, and it's a very more of a very slow growing type of tumor, so that we could afford her the opportunity to go to Hawaii. So I don't want to put out there that just because you have cancer, oh sure, you can go on a trip and we can wait. Some cancers, not every cancer is created equally.
Yep.
And I think we just need to do our shared decision making with the patient to make sure we're all on the same page and we understand the risks and the benefits of waiting or doing something up front. But in that regard, Lori's cancer was one that allowed her to go to Hawaii, if you will.
But I like you bringing that up though, that those conversations do happen on a personal level.
Yes.
There's things that patients have to fight for. It's family, it's trips, it's life.
Correct, and
Yeah.
I'm a very big proponent of that. It's a matter of making sure you're not just treating the disease in front of you, you're treating the patient, the family, and I think that's the approach that we bring here at the University of Kansas. We're really trying to treat our patient and their family.
Let's talk about, we talked right off the top of the show, I think when people think lung cancer, we immediately go to somebody who must have been a lifelong smoker, and then when we find out that someone has never touched a cigarette in their life, it's just baffling. Where does that come from?
So unfortunately, what we're seeing historically, the number of lung cancers that were from non-smokers were fairly small, but we're actually seeing that number slowly increase over time. And what we're finding out is that there are a lot of environmental factors, whether it's air quality. I know people have heard of radon, other buzzwords that are there, but in essence, anything that you're doing that is bringing badness into your lungs from the air can affect you in a bad way. Not everybody is the same. So some people are affected a different way than others. So unfortunately, we are seeing an uptick in lung cancers that are from non-smokers. Unfortunately, those tend to be more in females. This type of cancer is not one of them.
Okay.
But unfortunately, we are seeing that in our society.
So that's tricky. Everything you're saying is tricky. So then what do you do about screening?
So, great question. So we do have a robust lung cancer screening program here at the University of Kansas. I will be giving a talk about this tomorrow, actually, at a conference. But essentially what we have is if you're aged between 50 and 77 years, or 50 and 80 years if you have private insurance, so Medicare is 77, and you've had a 20-pack year smoking history, which means you've smoked on average 1 pack per day for 20 years, or 2 packs per day for 10 years, or half a pack per day for 40 years, whatever that number makes 20, and then you're either have quit smoking or have quit smoking or quit smoking in the last 15 years or are currently smoking, you would qualify for lung cancer screening. So that's if you go to see your PCP, there are the trigger buttons that say, oh, you're due for a colonoscopy or you're due for your mammogram. They actually have these built into EMRs now where they say, oh, hey, if you input the right data, it'll trigger you to say, you might qualify for lung cancer screening. So
great information. Thank you for sharing that. Let's get to some questions from our viewers this morning. Jeremy is asking, what are the criteria you look at that makes you say this should be done robotically versus this should be done traditionally?
I think our default right now is robotically. Yeah. I think that we start with, yes, this can be done robotically, and we almost have to get proven that we can't, if you will.
That makes sense. Lori, Melissa is asking if Lori changes her hair color like she changes Christmas tree bulbs.
No.
No, it's purple all the time.
Purple all the time.
Why purple? Is that just your color?
Yeah.
Okay, I love that.
Yeah.
Scott wants to know how many lobes you can live with.
So a lot of it depends on your underlying lung function. So people can live without one whole lung, and it all depends on how good is your other lung. So there's no great answer.
Okay.
But you can't live without all of them.
You can't live without all of them. Okay, Karen wants to know what are some common signs of lung cancer people often overlook?
So, unfortunately, lung cancer does not give you symptoms until it's too late. So I think that is a big message that we need to get. Lung cancer remains the biggest killer of all the cancers, compared with, colon, breast, prostate that are very, very common. And actually, lung cancer is a little bit closer than what we think. 1 of every 16 Americans is going to develop lung cancer in their lifespan. So as Dr. Nagy was saying, lung cancer screening becomes crucial in order to try to diagnose this one earlier.
Heather wants to know if insurance covers the robotic biopsy or lobectomy.
Yes.
Yes, okay. I want to ask, I'll start with you, Dr. Postigo. What do you want the big takeaway to be from this conversation? What do you want people to really take home?
I think that we need to realize that lung cancer, we need to change how we are approaching lung cancer. Is we want to change those trends and start, saving more lives. I think that we need to diagnose earlier. I think that the technologies that we have here at the University of Kansas are helping us to diagnose earlier, like robotic bronchoscopy, and then robotic surgery can diagnose and potentially cure those cancers earlier. Right now, unfortunately, lung cancer is being diagnosed pretty late. For every 4 patients that we diagnose, 3 are not going to survive by year 5 because, again, we are diagnosing too late. So lung cancer screening is super important. And, just if they find a nodule, let's make sure that we apply all the technologies that we have in order to diagnose it early so we can provide the best survival that we can.
Appreciate your passion, Doc. Thank you so much. Lori, so happy to hear you're in remission and doing well. What's the big takeaway from your story?
Well, just make sure you get checked for anything because it can just pop up. It's like, I never thought in a million years that I had this nodule, and I guess having the leg issue was a good thing in a sense because then they did all the testing and whatever and said, so now I feel good. I don't think they'll find any more. I'm just keeping that faith. Still have the leg issue, but
But you'll take it.
that'll be another whole thing. Yeah.
Right.
So, but yeah, just make sure, especially if you smoke. Even if you don't smoke a pack a day, you only smoke a couple or whatever, just have it checked. Like I said, it wasn't something I ever thought I would have because I didn't smoke, but it's just, it's like having a mammogram or a colonoscopy or, just do it. Insurances do cover it, so.
Well, we're glad you got it checked out and you're
Yep.
doing well. And we just appreciate you sharing your story.
Thanks.
Thank you so much. A little comment came in for you this morning from Tina. And she said, Dr. Naji is a great doctor. He performed my lobectomy in August of 2024. So,
Awesome.
little shout out to you this morning.
That's awesome.
And I know you got to get off to surgery, so I'm going to let you wrap us up on this Friday. What's the big takeaway?
Be an advocate for yourself. I think the most important thing is understanding that we have the help. There's help out there to help you, and I want to make sure that we understand that lung cancer has a bad stigma to it. It's we smoked or they deserved it or what have you. But Dr. Postiga's right. It's the #1 killer in the United States for all of our patients, both men and women. We need to be more at the forefront, be more aggressive in treating it, understanding it from a research perspective, and having that reducing that barrier to care. I think what we have is we have a large state that has a significant rural population that doesn't have access to care. And every time I come on here, I say access to care. 18%, the national average is 18% of patients who are eligible for lung cancer lung cancer screening actually get screened. It's in the state of Kansas, I believe we're at 21%, and I think we're only ranked 14th nationally.
Wow.
And Missouri is ranked 27th nationally. I think they only get like 16 or 14% screened. So there's a lot of patients out there that are eligible that need to be screened.
So we could do better.
We can do better for them.
Thank you. Thank you so much for your insights. So great to have you on.
Thank you.
Thanks to all of you, all of our guests, all of our viewers. Thank you for being with us. Have a great weekend, and we'll see you back here on Monday. Coming up Monday on the Morning Medical Update, determination. Jennifer Heck didn't let a cancer diagnosis change her dreams. I'm Jessica Lovell on the next Morning Medical Update. Diagnosed while getting her law degree. Jennifer pushed pause, not stop. We catch up with the now graduate Monday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.